Hello, everyone. Welcome back. Hope you had a good cup of tea or still making it. We have a gentleman all the way from Finland who's joining us, John Knight. John, just introduce yourself. You take it away.
Sure. Great, and thanks for inviting me to this session. As you can tell, I'm not Finnish, but I have been studying at Aalto University. Hang on a second, sorry. So yes, as you can tell, I'm not Finnish, but I've been studying Aalto University for the last 10 years, and primarily focused on service design. During that time, I've done a number of case studies, and I'm going to talk about one today. And really, the main point of the presentation is to share some insights into service design methodology, and particularly around health and service design. And as well as my academic studies, I'm a practitioner. So I've been working in digital design for 24 years, and always worked in the creative industries. I'm not quite sure how the video casting works, so I'm guessing if you want to ask a question, just shout. And I'm going to go for about 30 minutes, and then we've got 10 minutes for questions. So this is a case study of a healthcare service design project few years ago now, but it's quite important both in terms of my studies and I think in terms of service design more generally, because it was a project that was well integrated into agile delivery. And I guess part of my studies has been trying to get agile delivery and service design working well. Because for me, service design provides the strategy and the transformational aspects of design, and agile production is the means of delivering that change. So it was a relatively short discovery project, and involved a number of different stakeholder groups. So there's the project team itself, and project team is important in terms of discovery because it included the developers and the technical architects that were building this new service. And the service was all around e-consultations. So maybe not so revolutionary now that everyone's been living and working remotely, but at the time, the idea that you could get help from your doctor remotely was quite a new thing. So we had the project team, we had a group of patients of all different kinds, and we had healthcare administrators, doctors, and the research team. And the discovery part of this was relatively structured, starting with workshops to gain an internal view of the vision for this service, and then interviews, workshops, and the workshops were primarily co-design sessions, prototype building, and then testing. And the novelty, I guess, here is that this service was it was agnostic in terms of modality. So it included a kind of screen-based digital service, but it also evolved into a conversational service, which I'll talk about a bit later. But I just realised I should really keep an eye on my timing, shouldn't I, here as well? So just bear with me. So the interviews and various workshops, nothing particularly new there. The method of analysis was quite structured, and I'll talk about that in a bit more detail. But you can see on the right-hand side, it was a recursive way of moving between the data and insights. And this was a really useful activity because it helped to frame the service vision in a kind of user-centered perspective, which was in some ways quite different from the project team's views. So another interesting novelty was that the work included a literature review, so an academic review of all of the relevant research in the area of e-consultation. And again, projects don't always have the resources or time to do this, but this was actually a really valuable exercise in identifying other research that we didn't need to do, because other researchers and academics had done a lot of work in this area. So it really helped to validate some of the thinking, but also to identify where there were gaps. So that's just a bit of an overview of the research part of the project. Now, I mentioned the analysis. So all of this various kinds of field work produced quite a lot of data and quite a variation of data. So you can imagine a literature review is, kind of documents. The co-design was sketches, visualizations, and then we had quite specific means of data collection around technology acceptance models, so TAM, and then interview notes. There's all kinds of different data, and this is why I went through this quite structured way of analysis, which I'm going to talk about a little bit in detail because I think it's quite useful to share from a practitioner point of view. May not be revolutionary, you might be doing this, but just to align how you take a lot of, in this case, healthcare insights and data and kind of make sense of it and make use of it in a structured way that means that when you present the findings, they have a level of robustness to them across all different types of data. So the first thing we did was a very quick top-down analysis. And this basically was a facilitated session where the researchers involved in all of the different activities basically shared their particular insights from an extremely personal perspective, so that as a group we could share and understand personal themes and interpretations of the data, and we didn't kind of go into documents and the actual data itself, just to kind of get a sense of where it was leading and the kind of direction of the data. So then we got into the more structured way of doing this, and this is using a model called Framework, which has been used in healthcare previously, and that involved taking and tabulating all of the data and then weighting it in terms of how in different ways. So that could be the frequency that a particular insight or topic had come up in the different sources of information. It could be about the importance. So the idea was that there was a structured way of going through what we'd found and being able to get a sense of, was this kind of a kind of outlier, or was this kind of a big theme? And this gave us the initial set of data themes that we could then go through into categorizing and then taking each data point and seeing whether it fitted or not, and then refining the categories, and then we went through that until we had a model, a framework that allowed us to account for all of the data of all different kinds, and then could analyze it in terms of deeper levels of intent and what it meant to the participant. And then we went through a few rounds of modeling and creating frameworks of the data until we had this kind of quite stable, solid version. And this was a intermediate version of that. So you can see that there are circles with numbers, and the circles represented in this case frequency, and they're also color coded between data that was coming from patients and patients that came from and data that came from GPs. And the interesting thing in this early model of how the data of the themes in the data is that many of these categories actually went across GPs and patients. And this was not something that was predetermined before we did the research. The topics came out of the data itself. And interestingly, the themes within that data were quite strong in terms of suggesting a deeper structure within it. So what I mean by that is that you can see there's a kind of theme around connectivity and a category of technology. Sorry, I'm using these terms quite loosely. If you're doing this in a more structured way, you'd be talking about themes, facets, and nodes. So these are themes, and within a theme, you would get facets. So within efficiency, that could have facets of how efficient the consultation is, and then within that you might get nodes, which could be about the elements within that category and theme. So the sizing kind of gives you a sense of the relative weighting of the data across all of the different sources. The color coding gives you a sense of, whether it's something that is primarily one group of users compared to another group of users, kind of concern and feedback. And then the relationships between the different categories gives you a further level of insight. So you can see in this prerequisites, there's it's all about quite basic things about how the service could work. So can you connect to it? Do you have the right technology to use it? Do you trust the technology? Whereas on the right hand side, you've got this more ambiguous kind of topic of quality, and that's really about the quality of the consultations. And this helped to map a roadmap and strategy for the service. So from that, we were able to create thresholds of adoption. So you can see at the bottom level, having stuff that connects and you can trust. If you don't have that, no one's going to, or less people are likely to adopt the service. If you get that right, then you start to get more rich experience, more features. And then at the highest level, you're looking at this kind of the quality of the consultations. So again, the point here is that the research wasn't so much a validation or elicitation of requirements. It was eliciting data about the current situation that GPs and patients and administrators faced, and then from that finding out how all of that came together into different levels of service sophistication, let's say. So and this is where we got the functional, the adoption, and the value threshold. And this was from the data, but also interestingly fits quite well with the notion of kind of incremental delivery. So, if you think about, rather than a service being designed and delivered in, its full glory, this research suggested that actually you needed to have a critical mass of users of the healthcare service for it to be successful and to grow, rather than it being a all bells and whistles service that people then come and use. And this idea of moving from thresholds, from where you have a basic service where you can start to gather data as well, through to a rich feature set which is built on the data that you get from that critical mass of users beyond, is a interesting evolution, I think, of service design. So there was more practical insights and more obvious things that, once we kind of knew the roadmap and direction of this service in terms of how it works and the exact use cases it supported. And again, we involved the various groups in that research. Now, as well as the methodology for building the roadmap and service, and the idea of kind of using a quite wide array of data sources, so not just primary research, but academic research. The other thing that I think that this project suggests is that services are not a one-off kind of perfect version, but in fact this strategy helps to define what the design is and then how it's delivered, but also beyond that, and using that kind of idea of the living service is something that's ongoing. So the design of the service is part of that, but it's how the human practices and the technological platforms work around that. So that's the kind of case. I'm going to go into a bit more about some of the consequences of this type of work in terms of methodology. Is there any questions from this first bit around the case?
We just have one question of how do you judge importance?
How do you judge importance? In terms of the coding, I'm guessing?
I'm assuming so. Emma asked this question a few minutes back, so it's one of your slides that came up.
Right, okay, so I'm guessing it was around this. So there was no judgment involved in prioritization at this stage. It was merely reflecting the weighting of the data on the assumption that the more data points, the more people talked about a particular subject rather than another, then that was more important in terms of the data. How that informed how the service was designed and built is another thing, because there was and there would need to be a rather than it being a kind of user prioritization, a technical and business prioritization of these requirements. But that was kind of outside of the remit of the research part of this project, which I'm concerned with. Some of it was also more conceptual, let's say, than concrete. So moving to the right hand side of this of that threshold roadmap, the actual features, what it does are possibly more sketchy than the more concrete ones at the beginning. And the idea is that really this beginning threshold is where data is collected and these other improvements are validated more. So it's basically creating the basic service to incrementally improve, which is an agile lean thing.
I think a question just popped up, sorry, John, from
Yes.
Ellie. She says, I'm not clear on the difference between frequency, a topic has come up, and importance.
Right. Okay. So yeah, from a research point of view, the frequency is the main thing. How the project sponsors define the importance is the importance of how it is in making the service viable. So in this case, at least, which was quite a short project, that wasn't so much within the realm of the research, if that makes sense. Okay, I'm going to move on now to just look at some of the implications of this work, which I said is, a few years ago, but has continued in terms of evolving practice. And so, and I'm guessing we have a few designers and researchers here. So the first part of this is that this idea of creating a shared view of what the service is, and that it is agnostic of any particular technologies, and it's delivered by multidisciplinary teams, has become formalized into this, within my research at least, this framework. And this framework is really about how the lessons and learnings of that case and others suggest design and research work effectively. And there's some specific things around service blueprinting, which I'll go into a bit more depth. But one of the things that came from the collaborative nature of the service design in that case was enabling different groups of people to take an active part in that work. So, for example, help making sure that developers and business analysts, all different kinds of people, can actively be involved in the code design of the blueprint. And that's maybe not so contentious now that everyone works remotely generally, and that blueprints are now tend to be digital and collaborative rather than stuck on a wall somewhere. So there's a level of formalism around service blueprinting that helps to elevate that practice from this research. The other one is about the modality of service design, and I'm going to show you some developments around conversational service design, where the service itself is not, as traditionally we've seen, a combination of people and technology and screens and touch points and physical interaction, but more around conversation and narrative. And it's an interesting, not just as an alternative way of realizing services, but also potentially as a more democratized way of building services out. The bottom two are more kind of practical things around how teams can effectively manage and deliver service design, which I can talk more about. So covered that already. So going to the next level. So if these are the kind of functional aspects of the work, and to do those, from my research, teams need to have these four elements working together at some level of synchronicity. teams that are only doing one of these 4 things, if they're only doing service design, or they're only doing design thinking, or mainly doing that, but without them working together, tend to be less satisfied. So one of the surveys that I ran looked at how these 4 practices work together between different teams and different levels of adoption, and teams that are doing all of these 4 things more than others tend to be happier and to deliver, have more impact in the work they do. So they're nothing particularly revolutionary or new. It's just in the combination of using service blueprinting to kind of align and develop a vision and strategy, using design thinking not so much for coming up with ideas, but just getting diverse groups to collaborate. So designers have this kind of intermediary role often, where as well as creating the deliverables, they are helping, they're like the glue between different teams. And then, we've seen the human-centered design, so the primary research, and then aligning with agile production is having the operational foundations to do that work. A couple of other things just to mention that I've found useful evolutions in my research and practice is the very popular and valuable double diamond approach. Lots of people have done different versions of that. I think it's a really good framework because it's well known in different organizations and outside design. It works. There's just a couple of things that make it, for me, work even better in practice. So in the real world running projects, divergent and convergent absolutely works perfectly. Just having a level of structure before you get into the double diamond, and a level of handover to where services get moved from design into production and operations, reduces the amount of rework and ambiguity I've found in healthcare service design. So from a kind of consulting point of view, just having that slight structuring at the beginning and at the end helps to deliver good services. And across those, having the blueprints, the service blueprints, as the kind of central single source of truth that all stakeholders and users and teams can work across. And that really, I'll maybe come back to that, but that kind of comes through in, I mentioned service design formalism, so around service blueprints, and that's essentially potentially evolving service design blueprints, not just from capturing requirements, but from them being a means of moving from design into production. So combining elements of agile planning tools, ticketing tools with service design blueprinting, so that the blueprint becomes a living document between teams, not just of everyone knowing what insights and what the service could be, but moving it so it actually becomes a production tool. And I mentioned the conversational service design approach. So this is taking a service design, a service opportunity, and considering it from an agnostic perspective, and using conversation and narrative to design and deliver the service. The advantages of this, so if you imagine that rather than visualizations being the kind of backbone of service production, of them being text is quite significant. So in terms of the kind of, at the top here, we've got the kind of research activities. Having a text-based service research elicitation opens up more data. because you've got potentially from an existing service analytics. You can also use narrative inquiry as a research tool. And all of these different streams of data should help to, as we saw in that kind of threshold, develop a robust service strategy. I won't go into the details of how that strategy and the narrative service narrative works into production, but just to say that having a centralized corpus of the service, so all of the key dialogues between, say, a patient and a GP, all of the kind of repairs and loops that you might get in the critical areas of a service conversation can be not only captured and used to produce a service script and for blueprinting, but it can also be part of optimization, because once you have the live service and you've got humans and technologically delivered conversational services, these can all be fed back into this central service corpus area, and also supporting, prototyping and testing through Wizard of Oz type research, but also using machine learning and automation to do that. So that's a little bit of kind of science fiction I just wanted to finish off with. But just to say there's some potential ideas of improving blueprinting that comes out of this research. And there's the structuring around the work. So I didn't skip over this, but this is basically a way of, again, aligning service and agile from an operational point of view. And then the key foundation practices and functions within healthcare service design. And then I went back through the case and how the data helped to develop the strategy. But the data also helped to really strongly point to where a minimum viable service could create a critical mass. So I think that's all my slides. If I am right, yes. So thanks for the opportunity to share my research. And if you've got any other questions, I'll try and answer them.
John, thank you so much for that. Really appreciate you sharing your case study with us. We have a few minutes, so if anybody has any questions before we jump on to our next speaker, please do share. Thank you again. Will you be making the slides available to us? Is it something that we're privy to, or is it?
I will be, yes, in the next few days.
Okay, fantastic. Yeah, thank you so much for that. I think that's about it, really. John, have a beautiful day in Finland, and we will chat soon.
Lovely. Thank you.
Cheers. Bye-bye.
Bye.